هيكلمنا عن ال extracranial embolization.
Many thanks, Dr. Hossam. Many thanks, chairpersons. Good morning, dear professors and colleagues. My pleasure to give a short talk about traumatic epistaxis with the cases done in our unit recently. I'm going to talk here about emergency epistaxis embolization following nasal and oral surgical interventions, or what is known as traumatic epistaxis. So epistaxis is bleeding per nose as the most common cause or form is being idiopathic, where there is no structural pathology identified. However, it is triggered by allergies, infections, and systemic causes like hypertension and the liver disease. In idiopathic epistaxis, usually you find fine or tiny tortuous small vessels in the territory of the sphenopalatine artery mainly. We are talking here about traumatic epistaxis. This is usually what we encounter is post-surgical. However, it can occur with facial fractures. Post-surgical, we usually encounter pseudoaneurysms. Pseudoaneurysms cause delayed hemorrhage from the nose or from the paranasal sinuses. Usually the patient presents with severe or massive epistaxis with an arterial injury involving one of the external carotid artery branches. As you know, the external carotid artery gives its first two branches are the superior thyroid and the ascending pharyngeal, then two anterior branches, lingual and facial artery, and two posterior branches which are the occipital and the posterior auricular artery, and then it terminates into the superficial temporal artery and the internal maxillary artery. So traumatic epistaxis, it means following a certain surgical operation, usually in T surgeries, you can find a pathology involving or affecting one of these arteries, as we will see in the cases. Traumatic epistaxis can also occur with injury involving one portion of the internal carotid artery, which is the cavernous portion, due to its close proximity or due to its presence within the cavernous sinus, with its proximity to the pituitary gland. So following transnasal surgeries or transnasal biopsies, patient can present later by epistaxis due to injury to the cavernous portion of the internal carotid. I'll show two cases with involvement of the branches of the external carotid here. The first one was a 17 years old male patient who was diagnosed with invasive fungal sinusitis. As you see in the CT image, we have the hyperdense material which is occupying the ethmoidal and the sphenoidal sinuses. He underwent endoscopic biopsy from the sphenoid sinus. 2 weeks later, this patient had an attack of massive epistaxis associated with hemoglobin drop and being vitally unstable. He was admitted to the INR unit for a diagnostic angiogram. That patient had placed the Foley's catheter in his nasopharynx or in the posterior nasal cavity, together with packing or heavy packing of the posterior nasal cavity to stop the bleeding. So the first angiogram was negative. As you see here, we have a diagnostic catheter or a Berne catheter in the external carotid with no sign of bleeding. Removal of the nasal pack and the Foley's catheter was done. So you can find here a large pseudoaneurysm, actually with active extravasation coming through it. This is arising after the termination of the internal maxillary artery, most probably at the origin of the sphenopalatine artery. This is an angiographic run showing the pseudoaneurysm together with contrast coming out actively during the procedure. We placed the microcatheter at the most distal point that we could reach, and then we choose here to use liquid embolic agent, which was globran mixed with lipiodol. This is the liquid embolic injection. And this is the control angiographic run, showing occlusion of the pseudoaneurysm together with its parent artery. epistaxis stopped immediately in the unit. Foley's catheter was permanently removed. They left few posterior nasal packs for around 1 day, then it was removed and the bleeding didn't recur. The second case is a 5-year-old female child who presented to the ER with attacks of epistaxis that was following a tonsillectomy operation that occurred 2 weeks following tonsillectomy. Patient was in another hospital, then referred to us. We did a diagnostic angiography under general anesthesia with a 3D, and this is the image. This is the first one, is the diagnostic angiogram showing a pseudoaneurysm arising from a proximal segment of the facial artery with a 3D image for the pseudoaneurysm. The choice here was being due to proximal to the main trunk of the external carotid, so we placed the coils, occluding the sac itself, and with another coils into the main trunk of the facial artery. Bleeding also stopped and didn't recur. Thank you.